We just want to start off by maybe explaining why we thought about this topic. Obviously, slow movement is something that is a hallmark of Parkinson, and you can see it present in absolutely every activity that people do. In order for us to have the diagnosis of Parkinson's disease, having slow movement, which means we have less amplitude of the movement is lost, also the speed of the movement is lost, and also there's interruptions in the movement. So it's not just about being slow, it's about these three characteristics of the amplitude, and that's why you hear often about how much we train amplitude when we do like rehabilitation programs. And then obviously there's also space for doing it faster as well and trying to keep the rhythm. So it's three characteristics that have to be kept in mind when we are assessing how slow people are. And besides the slow movements, obviously you have the other symptoms of Parkinson, the rigidity, and also the tremor that might not necessarily be present at diagnosis. But this one specifically has to be. And today we're going to focus on eating and talking and how slow movement influences these two activities specifically.
So our goals today are going to be discussing how the impact of slowness will influence speech. We'll discuss ways to manage that impact. And then we'll go into how that influences swallowing and meal times, and then again, how to manage the impact. Within speech as well, we'll also talk a little bit about language and how changes in cognition may happen as well, part of slowness of cognition. So we're going to start right now with recognizing the impact of slowness on speech. And as Josepha mentioned before, bradykinesia, or slow movement, is one of the hallmarks. It is the hallmark. It must be present when you go through like the UK brain bank criteria when you're diagnosing Parkinson's, and it has to be in conjunction with some other components, whether that's the tremor or the rigidity or the other things. And so when we look at the slower movement and the smaller movement, because as we mentioned before, it's not just slow. Sometimes it starts off normal when you're doing the test with your doctor and it gets smaller, or maybe you can talk louder initially, but it trails off over time. Those are two reasons why you might experience something that would be considered bradykinetic, and that results in quieter voice. And also you're going to have reduced pitch change. When you bring your pitch up to ask a question, or if you're doing a series of something, you say this is the first thing and the second thing and the third thing. And you know that I'm done talking that way. So those pitch changes are pretty important. And if those get impaired because of this slowness in conjunction with rigidity, then you have changes in your communication ability, and it can influence how you're able to communicate with others, whether it's at home or out in the community. Another thing that's interesting is changes in rhythm and timing, because we use a lot of timing whether we realize it or not. There's what we call prosody, which is kind of like the music of speech. And as humans, we do that in a very intuitive way, and we recognize it. We're really human pattern recognizers. And so that gets influenced by this change in speed. And also you might actually, with the rhythm, you might actually influence your what we call fluency or stuttering. So it's not always just people who are having a hard time starting a word. It can also be maybe keeping the certain syllables in line, or the rhythm of that as well. So it can be a very, very complicated issue. So speaking directly to communication, how does the slowness affect communication? I'll start at the very top and kind of work my way down here. Facial masking is going to have a huge influence, because people read your faces all the time. You're using the facial expressions to recognize, agreement or confusion, and we use eye contact quite a bit for that. Now that can be influenced a little bit by posture. If your posture is forward leaning, you're not able to make the eye contact you want. But also if you're losing some facial expression and maybe it's not as clear, that's going to have an influence. The speech performance with what we call the articulators. And articulators are the lips and the teeth and the tongue and all the things that we use to shape sounds. When we're making language and speech, what happens is you have column of air. It comes up through the vocal folds. That makes a sound, but that sound is not distinct. And then we shape it with our tongue and our teeth and our lips, and we shape it into speech sounds. And so if those aren't moving as quickly, what will happen is the tongue might not get back to the back of the front of the teeth to make a T sound, and now it starts to be making a more of a has a little frication in there, has a little noise. Or it could be a situation where the timing isn't correct and all of a sudden parts of the words might fall off. You see this when people run out of breath sometimes at the end of a phrase and they don't have enough air, and all of a sudden it's just the word cuts off a little bit. Specific to voicing, a couple things that you'll say, well, when you say slowness, again, I'm thinking not just speed, but also amplitude. If you're not getting proper closure and opening of the vocal folds, especially if you don't have enough air, then it's going to come off as quieter. That's one factor. We know that as a real hallmark of Parkinson's. But also it can come off as a little harsh because the vocal folds kind of go in a very coordinated movement, and if that mucosal wave of that movement gets interrupted because one side's not moving properly, now you're going to get harsh sounding. So some people sometimes feel that they sound hoarse or raspy, and that's often a function of the vocal folds not firing in conjunction properly. And then breath production, I beg your pardon. Breath production itself, you're really relying on that to provide you with the column of air that you need in order to get speech sound. And again, if you're not using the full capacity of your lungs, if it's either with posture or in this case, because you're not opening them up all the way, you're not moving them as quickly and as fully as you could, then you don't have as much air, and all of a sudden your speech becomes quieter as a result. So that's the analogs here of the bradykinesia. And again, bradykinesia is the one feature of Parkinsonism that must be present in order to diagnose Parkinson's in conjunction with the other ones. And I would say, as a speech language pathologist, when I hear someone who is not quiet, it starts making me suspect there's another diagnosis, unless that person was previously a professional voice user of some type, and then that happens too. Like if you're a teacher or if you were a singer or something like that, you might have a really strong voice. But that's why I think the bradykinesia and the quiet voice kind of go together as hallmarks. And again, I'm a speech therapist, so my bias is towards the voicing. But within the medical community, the slow movement is absolutely a hallmark. There's another component of this, and again, we like to combine Latin words, or this is actually Greece, is brady meaning slow, kinesis meaning movement, that's bradykinesia, that's slow movement, but you can also have slow and phrenia meaning brain, and so they're saying slow cognition. And it's important for people with Parkinson's to hear this again and again. That's not the same as someone dealing with a dementia or somebody dealing with a loss of memory where they can't remember episodes. It's much more about a slowness of processing, and it takes more time for information to come in, and maybe you're listening and someone's talking too fast, or there's a bunch of noise in the background, and it makes it harder for you to put that into your head. And then if you don't take it into your head because of that issue with the speed, then later on when you're trying to recall it, well, you didn't encode it very well. And so again, what happens with someone with like an Alzheimer's type dementia is much different. And with Parkinson's, it's a matter of the ability to take the information in a timely fashion, process it, and keep it and encode it so you can bring it later on. Another thing that we see quite often is issues with task switching, going from one activity to another, or one conversation to another, or a conversation while you're monitoring while you're walking so you don't trip or something's coming your way. And that's a big part of why Joe Zappa and I teach classes with dual task exercises. We can work on that skill. You can make it stronger. But in general, people with Parkinson's, just due to where the basal ganglia is responsible for with autopilot kind of activities, can be impaired, and it makes more effort. Instead of being able to do something kind of automatically while you're controlling something, now you have to put your attention to this task, and then when it's time to do this task, you got to put your attention to that task, and that becomes a little bit tiresome, and things get broken down a little bit.
John, I was gonna add in when the struggle for people to actually get into the conversation, right? So getting in at the right moment, someone is talking and then they give a little space between another person coming in. And if we're not fast enough, then someone else is always coming in. So it makes it really difficult to maintain the conversation. Sometimes what I'll have is some people that say, well, I have to tell you this now before I forget, right? So they come in and they see that two people are talking, and then they interrupt it because they're so afraid of forgetting what they were going to say. So I think this has a bigger impact than we might be aware of.
I think the getting into the conversation is something that I hear so commonly, and you're quite correct about that. It's a very big factor. I think the other comment, and you're the first person that I've heard mentioning that about people saying, I want to get this out before I lose it, again, has to do with maintaining focus. So it ties in with that third point I was just coming up to, which is, again, because you have to spend energy taking the information in, if there's a distraction, whether that's a noise, whether that's a visual distraction, something walking in the background or something else happening, it makes it more effortful, and again, that makes it harder to to be able to fit in that. And so again, culturally in the United States, I think we tend to talk a little faster, a little louder, a little more aggressively. I think there's more space than a Portuguese conversation. Did you have it?
No, I say, or European in general. It's
Yeah.
just the speed is important.
Yes.
I have to always use a cue, like put up my hand, like, okay, I want to come in at some point.
Yeah. Should move that there. I do want to say that this impaired word finding, this tip of the tongue syndrome that so many people with Parkinson's are dealing with, it's again, it's a retrieval issue. So it's not like the word's gone. It's more like it takes more time for it to pull up there. And I think, again, that really speaks to the speed of processing. And I say speed of processing means it's not so much that it can't get there and get all the way back, but once you throw off the timing a little bit, then the sequence gets impaired and you have to repair it somehow. And that's really what the issue is. And that's why so many people, when you're dealing with this tip of the tongue syndrome, the word comes back after a couple minutes. It's never gone, and it's just part of the process. So we went through with our surveys, and I want to thank everyone again for putting your information to our surveys. It really makes us really think about what we're going to talk about, so we don't talk about everything, but we really direct it. And it was very interesting what people had to say. When we went into it, we looked at these, and it tracks pretty much with what we were expecting, where say many people, about a third of people, are experiencing pretty significant issues with their speech. Another quarter of them reporting having some problems. So a little bit more than half of people are dealing with some issues with speech. And that's what you would expect, especially earlier on. I think that the things that people are saying is not so much about, forming the words, but it's actually just kind of getting their point across in longer form. A single word or a couple words, that's not that challenging. Keeping it throughout a phrase or keeping within a conversation is where things break down. This is another part where people are asking about how it may have affected the way you interact with others. And again, fully half of people say often or always it's affecting it. And again, I think this gets to Josepha's point about getting into the conversation at the right time. I think people are frequently frustrated when people are talking too much. And then if you add in sometimes, now you're talking about 3 out of 4 people are saying that the speed at which you talk has influenced the way people talk when they're talking to you. And only very few, only 8%, 8.3% said never.
I would also add that usually if you are already with someone, so you imagine your partner is someone that talks more, so there's a normal tendency for people to talk less when they're next to someone that talks more. So even if you don't have Parkinson. And so I think when you have someone with Parkinson, the tendency will be to talk even less. If you, by nature, already talking less, you can see the isolation there. So hopefully it takes a team to understand and to be able to push the conversation and the moment that we give space for others to talk as well.
Yeah, giving some space, making the environment, maybe having some cues that you've used. These are all techniques we've discussed where you can, as a care partner, make it easier for the person with lived experience to actually navigate these conversations. And especially if they're talking with people who aren't familiar with them or you're in a big noisy environment.
The person might not like to talk, right? So I think there's also space for that, which is learned behavior. So the less you talk, the more probability of you talking less or feeling more comfortable not talking. And I think that the risk of this, in case you are a non-talker, is we need our computers to work. So it's very important for cognition that people have this interaction and social interaction. So it's important to talk so that we can keep our minds well.
You said something really important there, and I don't want to take us down a track too far, but I think that that tendency to talk less, or maybe your persona is perceived as more calm or relaxing, or maybe you're even more serious. And I always wonder where this comes from, perhaps maybe with the early symptoms of Parkinson's being facial masking or changes in your voice, if it's something where it happens so much premorbidly that it becomes part of your personality. So it's kind of a the opposite of a virtuous cycle. It's become something where it starts off, people perceive you that way, they reinforce it, and you kind of internalize it. So you've hit on something really important there.
And I would just add that I think, from my experience, that I'm not a talker, that if the topic is enthusiastic, people will talk. So I think it always goes back to the what we are discussing, and if we can really pin down discussions where that motivate us, I think that people will talk.
Yeah, yeah, for sure, for sure. Just to kind of break through some of the things that people have said here, it ranges from frustrating or have to guess what someone's trying to say, to terrible, very hard to understand. And then I think some people are really realizing how hard it is to have to feel like I'm sorry, what did you say? I didn't hear you. I had to keep asking someone to repeat themselves. And then I think that coming from the people with Parkinson's, I think the thing that they keep reminding people is that the people who have learned to be patient with them are the people that they have the best communication. And I think that's a valuable thing to keep hearing. It's like Joseph is saying, that the slower you explain it to me, the faster I'll understand it. And I think the reverse is true here, which is like, if you give me the space I need to speak, I'll say it more effectively, and it will be a better conversation than feeling like I have to keep up or you have to slow down. It's like just set the pace properly.
I think with the positioning would be worth also mentioning, which is sometimes I will be in house calls and like the care partner, independently if it's woman or man, will come in and from a distance say something. And obviously the person is working out or in a specific position. So it's the attention is compromised already. So being able to be closer to the person and will reduce the frustration of having to repeat.
Yeah, for sure. I mean, environments matter for that as far as space, distance, and sometimes lighting and other things can factor into that as well. Um, this thing I think I wanted to bring up about group settings is really important, because I think group settings, once you start taking it out of a comfortable environment like your home, you really, my animation's not doing what there, really shows up in a lot of places. So it's, needing more than one try to get my point across in a public environment, or I need help most of the time or all the time, or not being able to get in the conversation as we were just talking about. I think that a lot of people notice maybe the way the friends or their professional colleagues or people they know in different settings like church or support groups might change in the way they're talking. And of course, people may interrupt you, especially if they're people that don't know you well. This is something that I wish we could educate the general community more, which is when someone seems like they're having more trouble communicating, that's not your opportunity to fill in the blanks for them. That's your opportunity to step back and give them the space so they can use their own words. So it's valuable to know, but unfortunately, we're a small circle here that really get it, in this group today. This is another thing, and this gets back to what Joseph was saying. It's very important that you don't cut the socialization out just because you're having these issues. We're hoping that when you leave today, that you have some tools and some ideas about how to improve those situations so that the communication can happen. Because social isolation it's the new cigarettes. Being isolated socially is the new bad habit. We were talking a couple of years ago about being in a chair all day. It's very bad. It's one of those kind of things where we understand that the socialization is a really important part of living well with your Parkinson's on a day-to-day. I won't go too deep into saying that people are noticing it. However, and being uncomfortable socially, that may have happened before. This one that I didn't want to, I used to enjoy meeting girlfriends for lunch, and now that is stressing for me, and I wonder in the future if it's going to change those friendships. I wonder who will still be my friends in the future. And I would just say that's a really heartbreaking thing to hear, and I get a very real point, so thank you for sharing it. And hopefully you'll be able to talk with them about that at some point. Or maybe you maybe you design it so you have a smaller group, so it's not a big lunch, but maybe it's just 2 or 3 of you at a time to make it less stressful, or you add in some tools to make it easier, like a personal amplification. So we've talked about the impact. I'm now starting to get into how to manage the impact. And so let me not jump ahead too far in my commentary and just say the first thing for sure is rehab interventions, particularly speech therapy, should be your first approach. And I recognize a lot of people from the classes that we teach, and the classes are great. But I would also add to that working one-on-one with a speech language pathologist that knows Parkinson's, that works with a lot of people that have Parkinson's, that has some expertise. And that's your baseline. And those people are the people you'll work with to get some strength, and maybe you do some of the follow-up with them, every 6 months, like the dental model, do some check-ins. You can definitely, with this, improve many aspects of communication, including speed. It's not just speed, but they'll also work on amplitude and some other factors. And again, as I mentioned, I think one thing I hear when I see people, especially we just did a live class, so I talked to some of you folks. When you do a speech therapy program and you say, I did it 2 or 3 years ago, I saw it, it was great, I had a great outcome, that's excellent. That means that you're stimulable. I would encourage you to go back to that therapist every 6 months or 12 months or whatever your insurance will approve, and just get a touch-up, just like we go to our dentist and we get our teeth cleaned and they make sure there's no big problems. You want to catch things earlier, and also that'll also help you maintain those gains. And then obviously keep coming to our classes, because we'll give you exercises where you can practice those gains and maintain them as well. So it's a big circle of how you keep things moving. People often ask me about medications, and quite frequently when people talk to me about how medications may improve their speech, I shoot it down a lot because there's not a lot of improvements in intelligibility. But actually, I will say that studies would show that speed is better, articulation, meaning your tongue going back to the back of your front teeth, or your lips opening or staying closed when they need to, whatever it is, that will actually improve a little bit, because those are movement related components, and anything movement related is probably going to improve with some medications. But when it comes to intelligibility, the studies seem to show that maybe that extra speed is not as controlled, or maybe the timing is still off a little bit, and therefore the overall impact is pretty questionable. And so I wouldn't rely on meds to improve your speech. They may have some real benefit, and I would just combine that with the exercise and the techniques that your speech therapist is working on with you. Similarly, deep brain stimulation can have some real benefits for movement and the ability to basically have a reduction in your bradykinesia, or it addresses the tremor. But actually, there are some changes in voice that are often associated. It just has to do with the leads, the placement, and especially for STN placement, but actually for both of them, for GPI too. But so sometimes voice can be influenced, and you actually need to do a little bit of therapy and programming after the DBS to optimize and get your voice back in shape. One last thing I always like to point out, and we were just in Philadelphia, and I just saw a couple posters where they were showing the influence on DBS will have some negative, very minor, but their negative influence on word finding. That's the only cognitive domain. They've been testing this ever since it was FDA approved in 2002. There are no other cognitive domains in which DBS has an influence, but it does seem to consistently tweak just a little bit word finding. Before I go on, I saw something in the chat. I just want to make sure I didn't miss it. Someone's asking me, isolation is the new, okay, Joseph did it. Yeah, isolation and social isolation, and they talk about social prescription as being a way to make sure people are being engaged in the community. And so I think it's very cogent to think about that. Exercise is important, sleep is important, medications, therapy, all that stuff, and then social interaction and community, and whether that's online with our group, or one-on-one in person, or with your friends, all those are parts of that. Okay, as we're going into things that maybe needed to be addressed, you should be aware of triggers. And one trigger that people don't think about often enough is how certain foods, particularly protein-rich foods, may interfere with medication absorption, particularly if you've had Parkinson's longer. I mean, people early on might not notice this, but over time you might notice an influence of that. And the key with that is just to make sure that you're taking your meds on an empty stomach and then timing your meals, and particularly high protein meals, accordingly. Any sources of stress that you're dealing with, that's another factor that could also trigger this issue with the bradykinesia. Sleep difficulties is one that I think it's very treatable, very addressable. You can work on a sleep hygiene program and get better. And then if you have any presence of any of the common psychological things that occur with Parkinson's, such as depression or anxiety. And then it's funny, we talk about other factors as fatigue. When we ask people, are there any specific patterns or triggers? Fatigue shows up over and over again. It's like 1, 2, the fadiga is Portuguese for fatigue. Fatigue and stress, fatigue and speaking in English is not the primary language. It's like those are all really common factors. And fatigue is a very common issue in Parkinson's. So not always something that you can avoid. You could have times when you're dealing with fatigue. Just be aware and give yourself a little bit of grace when you're dealing with maybe more communication issues in the presence of that fatigue. And either try to mitigate it, give yourself a little break, take a little nap, take a little time, but also realize that maybe if you're feeling fatigued, you're not going to be on your A game, and that's okay. And don't get too frustrated about it. You can just advocate for yourself a little bit better. That's where Joseph was putting your finger up when you're trying to communicate is a good option. Put your hand up when you want to talk. I beg your pardon. It's funny, I look at a restaurant like this, and the older I get, the less interested I'd want to go to a place like this. We were in a conference in Philadelphia, and Josepha went with some folks from Parkinson's Europe to the oldest pub in Philadelphia, and that sounded terrible. And then I went to a place where I met some friends, and we ate at a little outdoor place, and we had a great time. And so I think the older we get, the more I say someone who has a better handle on making their restaurant not noisy is valuable. And so if you're dealing with this yourself, you have to be picking this, and that's looking for places that aren't as noisy, that don't have.
I was going to share with everyone that in this forced experience, I did find a new strategy for us, which is you put your AirPods on, which actually they actually cancel sound. And what was fun enough, I could actually hear the conversation that was close to me, but I isolated the sound around me. And I thought I was just going to not hear anything at all, but it was an intriguing and learning experience. In case you are ever forced to be in those type of environments, earpods work.
Yeah, no, I think they're very, they actually, AirPods have been FDA approved as an over-the-counter hearing device. I think they're really a powerful tool. Again, background music, live band, unless it's like a jazz band or a pianist. I mean, those are things that I would avoid. And then also visual noise. And so we talked about this in the past, but again, if you're going to a restaurant, maybe you can find a place that's in a corner. Maybe you can face the wall where it's pretty artwork behind you, but you don't have someone walking back and forth, because unfortunately, as human beings, we've been programmed for thousands of years to be aware of things approaching, and so you have a real tendency to get distracted when something's coming back and forth. And if you're in an environment where you're in a group dining setting, like if those of you who live in like an assisted living or independent living or something like that, again, I'd preferentially find the places where I don't have the people moving in and out, or the servers coming out of the kitchen. It's just a lot of extra work. Not that you can't do it, but you're just adding to the amount of energy and effort you have to use to keep yourself focused on the conversation. And I think keeping shorter times at the table is also valuable. I don't know how that would work in Portugal, because regularly if I've had a Portuguese lunch that has lasted less than an hour, I'm sure the Portuguese government would send me a citation. And I've been at a billion meals with Josepha's family that have been 2.5 or 3 hours. But for Americans, consider not doing that. Maybe you have a little less strain, just shorten it up a little bit. I'm teasing a little bit, Josepha, but it's a very classic, old school, amazing part of how your family is connected, and I think it's a good thing.
Above all, it's not only affecting your overall fatigue in terms of talking, as once you try to get out of the table, it's going to be extremely difficult because you've been stuck there for some time. So it will have impact then on mobility in general. And sometimes we tend to forget that. It's like, why? Besides the fact that you just had a large meal as well.
Yep. All that postprandial stuff here. So another thing we talked about is hearing. So if you have a hearing issue, if you have that diagnosed, definitely get your hearing aids. If, like Josepha, you get stuck as her in a position as the president of Parkinson's Europe, having to entertain at a loud event, use your AirPods, that's also fine. I would also say that vision is another one that is highly associated with your not only your cognition but also your ability to be interactive. And so if you haven't updated your prescription, be sure to take a look at that. Those are two easy things you can do, and there aren't many easy things you can do to fix this. And realize that not addressing that means, again, you're spending more energy to listen, you're spending more energy to take the information in, and it just wears you down a little bit. I love this one again. Here we asked people again, what do you feel your loved one or you can do to best support someone with Parkinson's in a conversation? And it's like, I hear, be patient, be patient. Here someone says patience, patience, patience. So they probably had this conversation. And I think the reality is slowing things down, taking your time. No one wants to feel rushed, and making space. And then if you have any way to keep the person included in the conversation without feeling like you're rushing them, I think that's what you're looking for. Do you have anything to add on top of that, Josepha? Well, I'm going to check this chat out real quick.
No, I would just say, be mindful of the first sentence, right? Because people, I think the frustration is really the repetition. I said this, right? So if the person with Parkinson has to be attentive about their voice and their volume, then as care partners, I think just be attentive about the way you say the first sentence and where you are in space. If you are directly looking at the person, if you are too using a right volume. So I think it goes both ways. We need to be a team here to be able to reduce all the fatigue around this.
So I think I just answered something I saw in the chat here. We're going to move on to swallowing and eating and meal times. Does anyone have any questions that we should get to before we move? We're moving from communication over to meal times. Okay, we're keeping control of the chat. If anyone has anything, you can unmute. Otherwise, I think we're going to roll into the next component here. So recognizing slowness on swallowing and eating, so how it influences and impacts it. And the first thing I want to do is give you the highest level, the literally 60,000 view of the 4 phases of swallowing. Okay, so we have what we call the pre-oral, which is from the plate to the mouth. So getting it off the plate into your mouth, whether it's with utensils or with your hands. I would say this is also where a good occupational therapist, or something like Nancy Hilmer, would have a lot of influence here, because it's not just about getting it from there to here with the utensils. It's also about positioning. PTs are also very involved. And as an SLP, I'll have my influence as well, but that's the very first part of swallowing. Once it's in your mouth, it's what we call the oral phase. And this is still voluntary. You're controlling it, you're chewing it, you're pushing it around with your tongue and moving it to the center and forming what we call a bolus, which is what we're going to swallow. So you're putting all the food together into a pile so that you can move your tongue up to the back of your front teeth and then push it. And when you push it into the pharynx, when you get to the pharyngeal phase, that's when you're really swallowing. And once it gets past into the pharyngeal phase, that's when all the volitional stuff that you can control voluntarily starts to disappear, and you get into the automatic portion of the swallow. So once you trigger the swallow, at that point, it's now in the autonomic nervous system's control, and that means automatic control is taking over. This pharyngeal area is where a lot of issues come into play, and it's what we spend a lot of energy as speech therapists trying to protect, because you don't want food getting into the airway. And then after it gets passed into the upper esophageal sphincter, and it goes into the esophagus, then the stripping motion of the esophagus moves it down into the stomach, and that is completely autonomic. There are some things I can do when someone has an esophageal issue, but it's very automatic. It's usually about controlling the amount of food we're eating. So how will slowness fall into place here? First of all, chewing food and preparing it for swallowing If you're not using the same force, maybe you're not keeping the lips closed all the way, you might have some issues with some drooling, you might have some issues with some food coming out the front. And just as much, the back of the tongue may get a little bit lazy or fatigued, and that means that instead of keeping the edge of the back of the tongue up so the food doesn't go into your airway, little bits of it may start to get back into the pharynx and get into a place where it could go into your airway, where it could be unsafe. With respect to your voice, before we were talking about slowness causing lower amplitude voice and maybe incomplete closure, it also happens that when you swallow, the epiglottis flips, the vocal folds come together, and if they're not doing that with enough force, you could have some airway protection issues where some liquid could get into your lungs. And then if it gets into your lungs, you want to be able to produce a nice healthy cough and expectorate it out. And that's another issue where, again, if you don't have that full force, you don't have that full energy, it's going to make it more difficult to do the airway protection, as we call it. And then finally, once it gets into your stomach, and a little bit beyond our scope today, but I wanted to talk about it, is the gastrointestinal issues, whether it's slow stomach clearance and slow emptying of the stomach, or whether it's issues with motility when it's in your intestines. Those are common issues in Parkinson's for sure. I want to just highlight it's important to talk about what I think are key indicators of a swallowing problem, because unlike speech, sometimes you'll have a situation where you can hear it very clearly, the speech is quieter, or maybe there's a fluency issue, or there's some other things. I think a lot of swallowing problems go under the radar until they become a real problem, until you get a pneumonia or something like that. So drooling is probably the first most visible thing, and it's common in Parkinson's. And I always like to say this, that it's not, you don't have more drool than you need, you don't have more saliva than anyone else, you're just not managing it as much. Just like you might not be blinking as much as you did before, you're probably not self-managing and swallowing your saliva. And I point to an older study by Hanneke Kolff at the Radboud University, where Josepha got her PhD, in which they did a 24-hour test of people, and they found that there was no more saliva in people with Parkinson's. It was just the amount of management. So if you have drooling, automatically I want to see you a little closer when I'm doing my swallowing exam, because you're at a slightly higher risk of having a swallowing problem. If you're losing weight without trying it, if you're not taking Wegovy or whatever, and you're losing weight, that's usually an indication that the meal times are having some issues. So it usually means you're not getting enough calories in, and that could go back all the way to getting from the plate to your mouth, but that could also be, just being able to chew properly, especially if the food is heavier or harder to chew or more complex. So unintended weight loss. Extended meal times fit right into that problem as well. If you're taking a long time to eat your meals, you're probably not getting calories in as well. And if you're getting to the point where you're getting fatigued at a meal, that's definitely going to be part of that factor. The coughing I mentioned is your body's early warning system. If you have food that gets into your airway or gets close to your airway, your body reacts by coughing and clearing it out. So if you're coughing at a mealtime, particularly when you're drinking a liquid, because liquid kind of goes wherever it wants to, that's probably an indication that you're having some food getting past your defenses. It doesn't mean that you're aspirating and it's going into your lungs and it's full penetration, whatever, all that issue. It just means that you're getting into places where it doesn't belong, and your body's reacting back saying, hey, get out, get out. And if you can address that at that stage, you can usually fix the problem much easier than if you wait until it's a real problem. Unexplained fever, that's where it's a real problem. That can often be an aspiration pneumonia. And an aspiration pneumonia means when something in your mouth gets into your airway and makes it into your lungs, and then that piece of food or liquid or whatever it is provides basically protein and sugar for a bacteria to colonize. It's a warm, moist place, and you're providing it with a food source, and it becomes a pneumonia. And that's the most important thing we want to avoid. You want to avoid the pneumonias. Now, there could be many other reasons why you have an unexplained fever. You can have a urinary tract infection. That would often be a source of that. You could have other infections or colds. As you can tell, I'm fighting a cold right now. So that could also be that. But if you're having recurrent pneumonias and it's not explained, it's time to really be sure that you're being aggressive about asking your doctor for a speech language pathology referral. And if you're working with a movement disorder specialist, they probably have already referred you because they're usually on top of this stuff. So I'm going to keep moving. I saw the thing in the chat, so we will get to that topic. I'm going to keep moving here. People noticing difficulties at meal times. Again, this tracks with what I believe. I mean, I think that the low awareness sometimes in people with Parkinson's, older studies, I remember they're not doing these studies anymore now, we moved on, but people self-reporting swallowing problems versus something that is done with a piece of equipment, an instrument, the variability could be 80% or more. People could be 14% recognizing a swallowing problem, and it's actually 94% of those people are actually having an issue. With our survey, 35% are saying that they often have a problem at a mealtime with slowness or always. If you add in the people who say sometimes, that's another 41.2%. So now again, we're back to that magic 75%. 3 out of 4 people are dealing with a swallowing and slowness of swallowing at meal times, and that's an issue. So occasionally, that's more the people who are never recognizing it or only having it very rarely. That's still a quarter, but I would point to the much larger numbers. And then, there you go. And then I do want to note here again that your spouse is recognizing it, or you're recognizing it yourself. That is, people eating much slower than they did before. I mean, that's a very large number. That's almost half. And then what you have, people eating slower and influencing their ability to complete meals, or influencing your meal that gets you to 15 out of the 21 people here. That's a very, very high number. So again, this is a common issue. It's something that I would consider working on with a speech therapist. I'm sorry, there we go. And again, in group settings, it only adds to the stress, so it makes sense that the numbers are even higher in public settings. So again, when we ask people what they notice, and whether they're avoiding certain situations, and yes, a lot of people do avoid social interactions. Even some people are talking about the issues with drooling, which again, if you're dealing with that, a speech therapist can probably help you with that. I have to say, botulinum toxin has come a very long way. It was something that was not our first go-to, but I see a lot of doctors using it quite frequently, and I'm happy to put out of a job. If it helps you with drooling, you might consider talking to your doctor about that option. It's very, very viable. And then again, this social one here, if I frequently swallow poorly and have to cough a lot, and then reassure people that I'll be okay, I'm sure it's a little bit at a meal with you, it might make people be concerned and make you feel like you're being, too much attention. But I would also say to this individual, if you're coughing and having an issue at mealtimes, I hope you're working with a speech therapist, because maybe there's something you can do to address that. And then you'd have the ancillary benefit of not having to reassure people that you're fine, and hopefully keep people from trying to give you the Heimlich or whatever. So, okay. Now, mealtime difficulties also go beyond swallowing, and again, this is where I think a good occupational therapist is worth their weight in gold, because we talked about using utensils and has it changed your ability to do this. So again, just under half of people report having issues using utensils at some point. At this Congress we were at, I saw a great poster where they were comparing the special tremor utensils with ones that are kind of more adapted, that have a kind of a swinging ledge, and then even weighted utensils, which I have never seen work really very well for Parkinson's. And all those issues were able to provide some benefit. And so again, if you're having problems managing this stuff, this is work with an OT. It probably work with your PT as well, will help improve this. And then talking about medications, again, this is something where people frequently report having issues. And so again, paying special attention or using adapted techniques such as crushing pills or something like that, I think those are important. If you're having problems with your pills and you're taking them, what I would definitely do is take them one at a time. I wouldn't try to do several at once. And our common technique is to take a pill and then take a sip of water and swallow it down. And I don't think that's great. I think actually you have a pill that's hard, that's rigid, and then you have water that goes wherever it wants. And so you got this really weird mixed consistency. I would take a little bit of applesauce, or I'd mash up a little bit of banana, or I'd crush up some blueberries or whatever, and I would give a bolus, put the pill in there, and then you could take it all down. You can use other things for that as well, but I'd be cautious about like cottage cheese or yogurt or pudding, only because those things will have protein in them and could interact with your medications. But I think the one thing to do is to get away from taking your pills with just water, because actually that you want the water, but take your pills with a bolus and then use the water to wash it all down after you swallow the pills. Okay, again, we're going to talk about how to manage impact for the swallowing issue. One thing that's always good is speech therapy, again, especially with swallowing, because some of it is hard to perceive on your own. It's good to get an expert pair of eyes. They'll find out where the deficit is, and then they'll strengthen that musculature. And then sometimes you can't strengthen it enough, or you have problems that aren't quite resolved. And then we could talk about compensating by using food that may be easier to chew or broken down a little bit, so it's not quite as much work. You definitely want to work on managing some of the triggers, and that could be, again, noisy environments, or being fatigued, or having stressful situations that are causing you to focus on things besides your mealtime. And then obviously we talked before about attention and things that are focusing your attention besides the meal. Sometimes, go ahead.
Yeah, I was going to add in, sometimes you might just be eating with people that eat faster than you. And so one strategy is to have them come into the meal a little later, or give them some salad to eat before you actually get to the meal. So by making people aware that slowness is an issue, I think there's a lot of human complicity where the other person can also try to slow down. So I'm highlighting here that there's a role for the person with Parkinson, but there's also a role for, obviously, for who you engage with, the partners and the family, to also be mindful of the slowness, and why not slow down as well.
I think that's very real, and I think I like what you're talking about with courses, because sometimes you can slow down the pace of a meal by having the salads come out or the soups come out, and then it makes everyone kind of have a certain timing with it, and it helps a little bit. So I think it's very cogent. I like that. What I don't think you need to do is focus on, like when we're working on speech therapy for voice, we want a certain volume, a certain amplitude, the ability to say a certain level of like a sentence or a paragraph. But I don't have the same analogs. We want to speed up the swallow function, but I don't think being faster, and that's not necessarily a goal. Obviously, you want to have.
Yeah, I was going to give another example. These are all based on experiences that I have, especially in the US. And one of them is like for the family that are hearing, and if you have any control over this, that the plates do not be removed quickly. So that means in a restaurant, as soon as they see that you have finished your meal, they take your plate away. And so what you will see is just the person with Parkinson with their plate trying to finish their meal, right? And I think this could be very awkward. So if we just hang on to our plates a little bit longer, it's just a very elegant way to make the environment less noticeable and more friendly.
I think I like that, and I think keep listening to tips like this, and Joseph will eventually make you all a little more European, which would actually be a good thing. For Americans, we could use a little bit of that. I just like to highlight again, as you start talking about meals that are difficult to get through, start getting rid of things that are really heavy intact things, pork chops and steaks and things like that. Raw vegetables, you can easily lightly steam vegetables and still be able to use them with dips and stuff like that. But celery sticks and stuff like that, it has to be a lot of work. Salads in general can be quite a bit of work, so sometimes it's nice to just have a simple lettuce salad and work on that rather than having all these different consistencies. Rice and popcorn and nuts and things that kind of scatter when you're swallowing them, those can be a little tougher to manage. And so if you're going to have those, particularly something like rice or something like that, you can add some sauces in them to make them kind of tie together, and that's a good way to do that. And then dry foods that don't have enough moisture, make sure you're either lubricating them a little bit with some condiments or some oils, or maybe you're cutting back on those a little bit. And again, for people who are dealing with drooling, sometimes I see after they've had their Botox, it's actually Xeomin, it's not botulinum toxin, it's a different brand, but it might have some dry mouth, and you want to be aware of that as well, just to make sure that you're not trying to swallow something without enough moisture. Again, I think there's a lot of great options with meat, fish, meats that have been broken down like a meatloaf or just a loose hamburger or a patty like that, poultry, adding in the condiments or the gravies, and then soft items like squash and stuff like that, or you can even puree soups. It's very European to take a soup that might look like an American vegetable soup and puree it with an immersion blender and make it very easy to eat. And again, culturally, that's exactly what they would have over there. They wouldn't have a big hearty looking beef stew. That's not really common. If you're having issues getting from the food to the plate, too, another thing to consider would be adding some finger food, so things you can eat with your hands without people looking at you in the restaurant. Although I'd say, do what you want, who cares looking at you in the restaurant? But cheese and fruit and nuts and olives and anything like that, those are all good options. And then people often ask me again, do medications improve your swallow function? I want to say first that it's a lot like speech. There are probably some things that do improve, but overall it's not going to be as much as if you would get some interventions to improve your swallowing. And then I also want to point out anticholinergics are not a common medication. Most of you probably are not on them, but those are medications that slow your system down a little bit, and it's usually for tremor. And it's kind of like taking Benadryl. It gives you that sensation. Those definitely do not help your swallowing. They make your mouth a little drier and they slow down your system. The dopamine replacing drugs, the dopaminergics, probably the voluntary parts, the chewing and stuff, that might improve a little bit, but overall impact may not be that impactful, that strong. Similarly, DBS will probably improve the volitional parts of it, the voluntary parts of it. It's questionable about the other ones, and then you have to worry about some of the side effects. I do want to point out that a lot of these side effects with DBS go away with proper programming, so it's important. So then we asked people what their techniques were, and we said, choosing food that doesn't require as much effort is a really good one. Eating and doing one thing at a time. I see being patient, that's a good one right there. And in swallowing capsules, I imagine is a matter of maybe pills that you can open up, like Rytari, you can open up onto a spoon. That might be valuable. Speech therapy will definitely help with slowness, especially for swallowing. And then this Life Vac Home Kit is for people who are choking. And I think it's an interesting thing. I hadn't thought of it. I looked at it online, and basically it's a way of helping people. It's almost like a device that helps people who may be under choking on food. And it's maybe not specific to Parkinson's, but kind of like having one of those window breakers in your car. If your car gets into water, it might not be a bad thing to have around. Anything can help. I mean, I didn't look; it was too crazy expensive. So I'll give it a thumbs up. Cautiously, I haven't used it myself. Yes, someone mentioned drink thickeners and gels have helped a lot with aspiration and coughing, and thickened liquids aren't my go-to with Parkinson's, but if you've worked on that with a speech therapist, it's one of these things where when nothing else works, they work really well. And I think they work particularly well with fruit juices that may have some thickness to them, like nectars, and things that are a little bit sweeter can often be very good. I haven't had great result with it with milk, but I mean, everyone's mileage may vary. Thickened hot chocolate, I always say, is I could sell that. I could take that to a college, and that would be like the drink that everyone would want. So take-home messages, guys. We just want to go clear it up because I want to make sure I'm not throwing us over time too much, but we'll answer questions, is managing slowness. But again, so much of this falls into rehab world. I kind of want to have Josefa talk about this. Is that okay?
Yeah, so I think if we think about any activity, right, and how Parkinson makes us slow, we take like maybe we took half an hour to get dressed, and now we take 1 hour and a half. And if these changes are happening continuously, we know that that's expected in Parkinson, that the disease will challenge you on this criteria of becoming slower. But it is important for people to identify if there's a sudden change, that we must think about what are the factors that are causing it. So it's important to be able to identify situations where are not expected according to what our knowledge of the progression of the disease. So whenever something happens, we should be thinking about, okay, when I have this slowness, imagine it's at the end of my dosage of taking medication. So it's just related to the time that you have taken your medication is important. So if I'm feeling that my thoughts, I'm having more difficulty concentrating, for example, then let me just think, is this happening when I am about to take my medication, which means the medication is probably not having effect, or is this something that happens after I take it? So those are important information to take to the doctor so that you can have adjustments. And I can give you an example, like if suddenly I'm feeling more depressed, by depression, like 2, 3 days, it's lasting. I wasn't depressed, but now suddenly I'm losing interest in everything, 2, 3 days. Depression would be enough to make me also think slower, to also move slower. So if I treat the depression, that means I'm managing the slowness, right? So that's how important it is for us to identify what might be contributing to the problem. And then obviously you have a whole bunch of health professionals that can help you try to target specific activities. What we discussed today was specifically to eating and talking as well. But in all the other activities, the rest of the team is there to give you tips and strategies for you to be able to reduce the impact that it might have. There's always space for us to mention how important it is for a good night's sleep. It's not like people don't sleep because they don't want to, right? It is very dramatic to be able to have the sleep hygiene, but it is possible. There are a whole bunch of strategies that people can use. And diet has its role, exercise, of course, and maintaining activity, social and mental activity is fundamental. And never underestimate the efficacy or the influence impact that support groups also have, because this is where there's a source of information that you actually had access to today by sharing your responses in the questionnaires. You are also contributing to the knowledge that we are trying to put together in these talks. So thank you so much for that.
Lovely. Yeah, right on the money. We've tried to answer them along the way, but I want to make sure if anyone has any questions, is there anything we can answer for you here?
I do have one comment. This is Nancy.
Hey, Nancy.
Hello. I know with the swallowing issues and the potential for getting aspiration pneumonia, uh, we would often do free water protocol and also combine that with really good oral hygiene. I think that would be one thing to kind of focus on to prevent aspiration pneumonia.
Yeah, and the Fraser Free Water Protocol that you're mentioning is actually here at Fraser Rehab in Louisville, which is in Kentucky, not Louisville, and it involves it means people can have as much water, not Coca-Cola, not milk or coffee or whatever, much real water as they want, whether it's thickened or not. And the key that you mentioned is as long as you have good oral hygiene in between meals. So after every meal, you're being very diligent in getting rid of the food particles. And then the rationale is that if your mouth is relatively clean, you can drink all the water, and the water may get some things into your lungs a little bit, but it's not going to be infiltrated with a bunch of food particles, particularly protein or sugars that can actually cause an aspiration pneumonia. So that's an excellent point. It's a great point to Nancy.
Thanks. This was a great talk.
Yeah, yeah, no, thank you so much. And
Yeah.
I,
I was going to ask, I was going to add in the last tip, just because now you can see me better.
yeah,
And which is there's a tendency for us to be eating where the head goes to the food and not the food comes to the head. And so it's like when you think you're getting slow, it's because we are getting closer to the plate. And so what I want to make you aware of is the position of our arms. So the function of our arms becomes, because of the rigidity and also the slowness. So taking the fork to the mouth is compromised. So if you are aware of that, there's a tendency for the arms to be close to the body. And so if you spread out your elbows, which in Europe I would never recommend this because it's considered not elegant, but if you do, that means your position of your hand is different than here. Here I'm not able to get, here I am in a position to move better. So just try it out. It's just a tip that I think is important, and some people try it and it works well.
here I'm selling on you how Joseph is going to make you more elegant like Europeans are. And then also stick your
They
elbows in.
suffer.
But it does, it's something important though. Yeah. Um, So yeah, it is a good way to own your space, and I think that's also important when you're trying to navigate the world where people are moving faster and sometimes ignoring. It's like, this is my space, this is my time. I need a minute to tell you what I'm going to say, and you have to own that. You have to advocate, and this is part of that advocacy. I
I have a question.
Sure.
Yeah, I'm somewhat unusual. I was drooling, and then I took the dopamine, started it, and the drooling went away. I've been losing weight, but we moved into a retirement home, and I'm eating twice as many calories as I ever had before, and I'm still not gaining weight. So I'm not quite sure what to do in those circumstances. I take my pills. I don't have much trouble with. I take some supplemental capsules too, and I somehow have problem. But I'm not going to have applesauce available because we eat in the diner, and I'm not quite sure what to do there. So
Okay. Well, first of all, with the drooling going away with the medication, so the medication is giving you either the capacity or maybe awareness to self-manage it. So that's excellent, and that's great news, and that's problem solved. I mean, if it's an ain't broke, don't fix it situation there. As far as losing weight, even though you're eating more calories, then I'd start asking your doctor because maybe you're having issues with absorption. It doesn't sound like it's the amount of calories you're taking in; it's the amount of calories that are being processed by your. So that would be questions about constipation or gastroparesis or something like that.
I've always had a high metabolism, and I had constipation problems, but I solved it with lots of prunes and coffee. So I don't know quite why. I'll have to just see if there's any reason, but it seems to not be any worse. But I'm back to where I was in high school. So
Yeah. So then I'd ask you if you're at a place that may have a dietitian on staff, it might be worth asking the dietitian. There are some snacks I can do to maybe your metabolism's still pretty high, your activity level might not be quite as high, and maybe there's something that you could be doing to add in some more calories. I know you sound like you're taking more in there, but again, your net answer is weight. Your net answer is not I took 3,200 calories in because I'm training like an Olympian. It's am I 150 pounds or am I 160 pounds this month or whatever, well, year. So I would
thank
ask that person too if you're in a facility where you can do that. As as far as the pill, the supplements that are hard, I like a little banana. Maybe you can liberate one from the facility, and I just I cut a little corner off of it, like I mean, talking like this much, a bite, and then I'll chew that, and then I'll just put the pill in there, and there's my bolus. I mean, you could have applesauce in a can, I guess, but that doesn't sound very healthy. But bananas are pretty easy. You slice off a little piece. Trying to think what other things you could keep around in an easy to use way that would give you a little bit of that bolus.
I can for dinner. I can order mashed potatoes most of the time. Probably that would maybe work.
Yeah, especially if they have a little gravy on them, it helps to have that. And if they don't have any gravy available, olive oil is a good one too. It's a good lubricant.
Okay, I'll have to be creative. Thanks.
Yeah, good perspective though. Okay, there's a question in here, but before I talk more, anyone else have any other questions? Um,
We
you can,
haven't. I can tell the family here is like, don't be afraid of silence. There's no
yeah,
need to fill in everything.
yeah. Someone's asking about bradykinesia and aspiration and bradykinesia and reflux. And I'm going to start with the second one first. Reflux is a very common issue in Parkinson's. It occurs at a much higher rate. I think I saw 8.7% when people were just diagnosed, and that goes up only over time. That is almost always caused by either stomach not clearing very quickly, and that's a kind of a gastroparesis, and so you might want to modify the diet, or maybe the doctor will have something for motility, but often you can do it with diet. But it does speak to the bradykinesia because there's also some laxity. There's at several points along the way, there are sphincters that close, and sometimes you get some laxity of the sphincter that's right where at the bottom of the esophagus, the lower esophageal sphincter, and you'll see that issue a lot. And again, you can address that a little bit with meals that are easier to digest as well as eat, but also you probably should talk to the doctor because there's probably a medication or two that you could add into the mix that'll also help with that. Now, as far as potential for aspiration in bradykinesia, again, bradykinesia, we were talking about slowness of movement. sometimes it starts off bigger and it gets less over time. You know, it starts bigger and it gets quieter or it gets less movement. And that's where I think maybe you might run into some issues where at the beginning of a meal, you're doing fine and your airway's being protected well, but as you get fatigued, maybe you're not closing all the way, or maybe things are not protecting it as well. And again, it's the same solution that Josepha was mentioning before, maybe shorter meal times, more frequent meals, maybe some snacks, so that when you're at a meal, you don't feel like you have to get all your calories in at the meal. But it's also a good reason to work with a speech language pathologist to see if there's anything else that you can directly address. I can't see it. And actually, even if I could see you personally, I'd really want to see it with an X-ray swallow study. I'd really want an instrumental exam. So you can modify your meals a little bit. You can work on not getting fatigued at the meals, but I think you'd also want to work with an SLP.
And I would just add in, if you identify this as an issue, try to relate it again to the medication. So if you are able to take your meal when you feel that the medication is having effect, it will probably have less impact. I know it's not always possible, but if it is, if you have a choice, it's better to have the effect of the medication.
Someday we'll have a better way of doing that, but right now I think your best bet is to track it yourself. And a lot of insights with when you're taking your pills and when you're experiencing certain issues. And not all of it's related to swallowing. It could also be related to mobility or communication or everything. So being aware of when you took your pills and how long they're lasting is very good advice.
Okay, no, I guess for time's sake, we'll have to say goodbye.
Thank you.
But do reach out to us if you have any additional question or more personal question. And yeah, we hope to see you again in our next program.
Thank you for joining us, everyone.